about chronic kidney disease, and I think the regular course of this year will be in May.
Yes.
Am I right?
Yes, it will be on the 15th of May, from 15th to the 17th of May, and it will be in Cairo, and we have 10 grants for accommodation for anybody from outside Cairo, whether Egyptian or non-Egyptian, from outside Africa, of course. Anybody from outside Cairo, we have 10 accommodations, but you have to register as early as possible. The details are on the website. It's called www.4ckd.blogspot.com. 4ckd.blogspot.com.
So thank you, Dr. Mohamed, for all these activities, and today Professor Nsr will give us a talk about what's new in era of protein-bound uremic toxins. And I asked him to just give us idea about the academic points and then to give us teaching points from practical points at the end of the presentation. Professor Nsr.
Thank you very much, Professor Hussein, for inviting me and for this very nice introduction. I'm always very glad to be in Mansoura because I have so many friends here. Of course, Professor Shaisha is one of my best friends, and I'm also very, very glad to see you all here because even though we are neighbors, we don't get in touch with each other that frequently. So I just need to ask, where are you from? Which countries are you from? Zambia? South Sudan? Gabon? Okay, so you're from all over Africa. Anybody from Nigeria?
We have guests from 13 countries.
13 countries.
13 is really
Beautiful.
So, but
Okay. Sorry?
I ask you just to be slow in pace.
Okay, I'll do that.
To allow the translation.
Okay. So we'll be talking about what is new in the era of protein-bound uremic toxins. Of course, it sounds very academic, and we will start academically, but then we will move slowly until we see how important it is from a clinical point of view. We will be talking about the updates. So before we go into the updates, we need to know what we knew from before. What were the old things that we knew? This is the oldest thing I could find from the literature. This is an article from 1888. It was a presentation, pretty much like this one, about uremia. And the author says a very beautiful quotation here. Uremia, he's trying to define uremia, is a disease, may be defined by the altered condition of health caused by the accumulation of poisonous products that should be removed by the kidneys. That was the definition in 1888. Interestingly, this is a paper from 2012, and the definition is, again, uremia is characterized by the retention of various solutes that should be excreted by the kidneys, and these solutes may interact negatively. When they interact negatively with our body and our tissues, they become called uremic toxins, and they cause the uremic syndrome. It's just the same, but a different way of saying it. It's just exactly the same definition that we had 130 or 140 years ago. But now we do know a little bit more. So, for example, we know that not everything that is retained, that should be removed by the kidneys and is retained in the blood of patients with uremia is a toxin. We call them retention solutes. If those solutes have a negative effect on health, they become called uremic toxins. And to call them a uremic toxin, you have to know exactly what you are talking about. So you have to have a chemical characterization of the toxin that you are talking about. You should be able to measure it. You can't just talk about any dream. It should be a measurable toxin. Of course, this toxin has to be higher in uremic patients than in non-uremic patients. And there should be evidence that this particular toxin is associated with some of the negative symptoms and signs or manifestations and complications that we have in uremic patients. This should be shown clinically, it should be shown in the lab and in vivo and ex vivo experiments. So this is the new definition of uremic toxins, a little bit like what we had 140 years ago, but with a little bit more details. Interestingly, again, from the same paper, I really like it because it is, if you look, I really do advise you to read this paper. You can get it on PubMed. It is so interesting to see how 100 or 200 years ago they were able to reach so precise conclusions with very little tools. And look at this quotation again. He's trying to figure out where the source of the toxins came from. And he started by talking about stuff that we take from outside our bodies, particularly potassium. And then he talked about stuff that comes from the disintegration of the tissues, the metabolism. And he also talked, interestingly, about number 2, the absorbed products of the intestinal putrefactions. Putrefaction, by the way, is the decomposition of proteins, not of anything else. And probably this is the only mistake that they have, is that they thought that the liver detoxifies those toxins by changing them and changing their chemical structure. Interestingly, the definition of uremic toxins in 2012, set by the UTOX group in Europe, tells us that the source, the classification of uremic toxins based on the source again is via endogenous metabolism, exogenous intake, or microbiotic metabolism. Microbiota are the bacteria that live within our bodies, especially in the intestine. Based on their characteristics, on how you can remove them by extracorporeal circuits, we have small water-soluble solutes, we have middle molecules, and we have protein-bound molecules. Today we will be talking about the toxins that are protein-bound, and they also happen to be products of microbiotic metabolism. If you need to know any further details, those 3 sources at the bottom of the slide are very interesting, and they have lots of information in them. So, today I'll be talking mainly about 2 toxins. One of them is derived from the indole ring, it's called indoxyl sulfate, and the other is derived from the phenol ring, and it's called the p-cresol sulfate. This is how p-cresol is formed. So we start by amino acids from proteins like tyrosine or phenylalanine. They become putrefied by bacteria to form something called p-cresol. This is an effect of the metabolism of bacteria on the proteins that we eat. P-cresol is then changed in the liver to something called p-cresol sulfate. This was thought to be a detoxification, but in fact it's not a detoxification. This is intensification of the toxicity. Because p-cresol by itself, produced by the bacteria, is not very toxic. But when you add sulfate to it, it becomes p-cresol sulfate, it becomes very toxic. And more recently, a very recent update, is they also found that if glucuronidation, if you attach a glucose molecule to the p-cresol, it also becomes toxic. It becomes p-cresol glucuronide. The other toxin, indoxyl sulfate, is formed in a very similar way, but you start with a different amino acid, tryptophan, and it's formed by E. coli in the GNT. This is a very interesting study because it proves this concept. It proves what was said 140 years ago, that many toxins are formed in the intestine from the microbiota, and it proves what I was just trying to show you, that indoxyl and cresol sulfate are formed in the intestine. In this study, they took a few patients who were on dialysis who had a colectomy for any reason, because of cancer, colon, inflammatory bowel disease. They don't have a colon, they have renal failure, and they're on dialysis. And they measured the level of indoxyl sulfate, p-cresol sulfate in those patients, and they found that the levels of those toxins were extremely low, the one in the middle, very low, because they don't have a colon. They're even lower than normal individuals with normal kidney functions. But of course, if you look at those at the far left, dialysis patients with a colon, they have a very high level of the toxin. You take out the colon, and they don't have those uremic toxins. So this proves that yes, without a colon, you don't have those toxins. So what do those toxins do eventually? Well, we'll be talking about three things that they do. They can cause inflammation. They can cause kidney damage. So we're not talking only about dialysis patients, we're talking also about pre-dialysis patients, and they can cause cardiovascular damage. This is an interesting in vitro study on granulocytes. So they bring some white blood cells, neutrophils, they put them in a dish, and then they add to them. Do I have a pointer? Is this a pointer? Dr. Hussein, the pointer? Sorry. I don't know. Okay, so these are the neutrophils. You don't add anything to them. If you just add p-cresol glucuronide, there isn't much of a difference. But if you add p-cresol sulfate, if you add p-cresol sulfate, there is an increase in the oxidative stress and the markers of oxidative stress released by the granulocytes. So p-cresol sulfate seems to produce lots of inflammation and oxidative stress through the granulocytes. And if you add p-cresol sulfate to p-cresol glucuronide, the inflammation and the oxidative stress increases markedly. So p-cresol glucuronide is not very toxic, but if you put it to p-cresol sulfate, they're very toxic together. And this is what we have in the uremic patients. In uremic patients, not in the dish, in the lab, we have both sulfate and glucuronide, and they produce a lot of oxidant stress. And this oxidative stress is probably the cause of most of the damage and the toxicity of those two protein-bound uremic toxins. Next, kidney damage. Again, we have this slide from cultured proximal tubular cells in vitro. They showed in this study, Sun et al., that if you add indoxyl sulfate to those cells, you increase the expression of angiotensin 1 receptor. You also increase the production of angiotensinogen and angiotensin. So you have a marked rise in the levels of angiotensin by adding indoxyl sulfate or p-cresol sulfate. We all know that stimulation of the renin-angiotensin system can be very toxic to the kidneys because it stimulates TGF-beta, it stimulates so many cytokines and angiotensin, and they're very toxic to the kidneys. They induce renal fibrosis. In the same study, they did something very interesting. Instead of doing it just in a dish, they decided to get animals and do an in vivo test. So they brought the animals and they injected indoxyl sulfate and p-cresol sulfate in those animals intraperitoneally. And again, there was an increase in angiotensin 1 receptor and a reduction in the angiotensin 2 receptor. Angiotensin 2 receptor, by the way, is the protective receptor. If angiotensin stimulates the angiotensin 2 receptor, you don't have renal fibrosis, you don't have hypertension, it's a good receptor. If you inject the animals with indoxyl and p-cresol sulfate, you have the bad receptor go up and the good receptor go down. And this could promote renal fibrosis. And actually this is what they showed. After injecting those animals with indoxyl sulfate and p-cresol sulfate, they started looking at what happens inside the kidneys. I know those slides look sophisticated, but they're very interesting. This here is a control, no indoxyl sulfate, no p-cresol sulfate, just a normal animal. And they stained it with E-cadherin. E-cadherin stains the epithelium, the normal proximal tubular epithelium. And you can see here we have good tubular epithelium. You can see the tubules, rounded, nice, beautiful. And they also stained them with alpha smooth muscle actin. This stains the fibroblasts. So this is a normal kidney. You have the tubules, you have a few fibroblasts every now and then. after injection of indoxyl sulfate, tubules vanish. And instead, you have in the same distribution fibroblasts. No tubules, tubules vanished, lots of fibroblasts. This is what we call transdifferentiation. This is a very serious complication that happens in patients with chronic kidney disease. We think that in many of those patients, progression is caused by a phenomenon called transdifferentiation. The tubular cells become changed and transformed into fibroblasts, and instead of having healthy kidney tissue, the healthy kidney tissue itself changes into fibroblasts. And it was shown that indoxyl sulfate and p-cresol sulfate can induce this. Of course, they're not the only thing that induces this, but they are part of the toxins that do this. Interestingly, by the way, in that study, I didn't show you that they also gave those animals angiotensin-converting enzyme inhibitors, and they found that this attenuated this damage. So there was a protective effect in this study. Next, we'll talk about the cardiovascular damage. Of course, indoxyl sulfate and p-cresol sulfate have been shown in experimental studies that they inhibit the endothelial proliferation, they stimulate shedding of the endothelium, they induce endothelial dysfunction, myocardial fibrosis, insulin resistance. These are all very toxic to our patients. But they also are associated with vascular calcification, which is a very serious problem. And this is another very interesting study performed on human endothelium obtained from the aorta. It's an in vitro study. And what was shown? It was shown that when you give those animals indoxyl sulfate, when you give those cells indoxyl sulfate, what happens is you stimulate the NOX4, which is a pro-oxidant enzyme. It's an NADPH oxidase. It increases the oxidant stress. But what is more interesting is that after increasing the oxidant stress in those epithelial cells, they found that the cells started secreting alkaline phosphatase and osteoprotein. They started transforming from smooth muscle cells of the aorta to bone cells. You changed the muscle of the aorta into bone. And they were able to stop this effect by adding an antioxidant. So obviously indoxyl sulfate and p-cresol sulfate again were inducing an oxidant stress in the smooth muscle cells of the aorta and changing them to bone. And you can stop this by inhibiting this oxidative stress. But this was all in the lab. And not everything in the lab applies to what we see in our patients clinically. So let us take a look at the clinical studies. We have clinical outcomes data. The clinical outcomes data show us that there is reduced renal survival in patients with high levels of indoxyl sulfate and p-cresol sulfate. If you have a high level of indoxyl sulfate, there is a higher probability that you will lose your kidneys, double the serum creatinine, start dialysis, than if you had the same serum creatinine but a lower level of indoxyl sulfate. Again, indoxyl sulfate, as well as p-cresol sulfate, by the way, were shown to be associated with aortic vascular calcification in chronic kidney disease patients. And it was associated with a higher mortality. The higher the indoxyl sulfate, the lower the survival. There is more mortality and more cardiovascular mortality. So, observational studies have shown us that those toxins are again associated with bad outcomes. But still, who cares? We are clinicians. Eventually what we want to do is to treat the patients. How can we prevent those outcomes? So this is what happens. This is what I was trying to explain. Those toxins come from, as we said, protein intake that becomes putrefied in the intestine to produce toxins. The toxins are absorbed. They go up to the tissues and they induce tissue damage. So if you want to prevent tissue damage, you can intervene at at any of those points. You can reduce protein in diet. You can manipulate the colonic bacteria to prevent them from producing the putrefaction. You can prevent the absorption of the toxins. You can prevent the drug from the toxin from reaching the tissues, or you can have an antidote. I'm not going to talk much about those two. Of course, we know that reduction of the protein in diet in uremic patients has not shown to be very beneficial, because even though it will reduce the levels of some of the toxins, but we know the problems that we have with malnutrition in our patients. And even when we restrict the proteins, this has to be within limits. Otherwise, you're going to do more harm than benefit. Maybe some benefit, but more harm. We don't want that. Or you could use an antidote, and we have already talked about angiotensin-converting enzyme inhibitors, angiotensin receptor blockers. They could be useful. We know that antioxidants were good in the experimental tests, but we know that they have not shown to be really beneficial in clinical studies. So we don't really like to use antioxidants, but I'll be talking more about those three in the middle. Removal of the toxin from the blood. Of course, nephrologists like to play with their machines. So they used this circuit, which is a circuit that we use for dialysis of patients with liver cell failure. You cannot use the regular dialysis machine because, as we said, those toxins are highly bound to proteins. They will not diffuse. They are bound to the proteins. They will not diffuse from the regular dialyzer, even though they're very small. They're bound to the proteins. So what we do is we have two circuits here. This is just the regular high flux dialyzer. We don't care about this one. But what happens is the blood goes through a special filter, something like the plasmapheresis filter. It's not exactly the same, but something like it. It allows albumin to go out. So albumin goes out from this filter with all the protein-bound toxins stuck on the albumin into another circuit. And in this circuit, it goes through an adsorber that strips off the toxins from the albumin. So we're pulling the toxins out from the albumin and then re-infusing the albumin back to the patient. Did it work? Yes, it worked. It reduced the levels of indoxyl sulfate and p-cresol sulfate markedly. Did it have any good clinical outcomes? We don't know yet. Till now, we don't have any data. Because I don't really care. If you tell me if you tell your patient you had 1,000 milligrams indoxyl sulfate, and after this very expensive session, it's only, instead of 1,000, it's 2, the patient doesn't really care. The doctor doesn't really care. What we care is this going to protect the patient from kidney failure? Is it going to protect them from cardiovascular damage? We don't know that, but this is promising. The next thing is we try to prevent the absorption. And again, we'll go back to that very interesting 140-year-old article whereby Carter was suggesting that maybe we could prevent those toxins from being absorbed by using charcoal. He wanted to use charcoal to prevent the absorption of the toxins. And actually, yes, recently, a form of, well, not charcoal, but more or less microcarbon, sophisticated carbon atoms were used to absorb the toxins from the intestine. Developed. It's a molecule called crimson. And crimson has been shown in some small, not very reliable studies that it's good for your kidneys. It prevents progression of kidney damage. It lowers the serum creatinine. It lowers the levels of protein-bound uremic toxins. And so a big clinical trial in about 2,000 patients was done. And those patients were given crimson to see if it will prevent the progression of renal damage. And it was shown that it will reduce the toxins. Unfortunately, it wasn't very successful to prevent the progression of kidney damage. But at least it was a trial. The last thing, which seems to be the most interesting, the easiest, and probably the most promising, is to manipulate the colonic bacteria. Of course, manipulation does not mean kill the bacteria. It does not mean give an antibiotic or an antiseptic. This is not right, because we know that we have very useful bacteria in our colon that help us produce vitamins and help maintain the epithelium of the colon. So, for example, in the normal person, in the proximal colon, you have saccharolytic bacteria which break down carbohydrates and produce short-chain fatty acids, which are very important for the nutrition of the colon itself. In the distal colon, you have proteolytic bacteria, and these are the bad bacteria, the Clostridia, the E. coli, the bifidobacteria. These are the ones that produce the indoles and the cresols and the phenols that cause the toxicity. This is normal, but in uremic patients, you have much less saccharolytic bacteria and much more proteolytic bacteria. And this happens because our patients have low motility of their GIT, because we are giving them so many drugs that alter the bacterial composition of their colon, because they do not assimilate and digest and absorb proteins properly. So even though they have a low protein diet, but still lots of protein reaches their colon. And this causes a disruption of the bacterial milieu, and they have more of those bad bacteria. So what do? We try to manipulate that. You can do this by giving more carbohydrates to those patients. Not any carbohydrates, we're talking about complex carbohydrates. We're talking about fibers that reach the colon without being digested. And this is what we call prebiotics. And this was shown in some studies actually to reduce the levels of uremic toxins. Don't know if it's going to be clinically useful or not, but it seems to be promising. Or you can actually give the patient bacteria, useful saccharolytic bacteria. And we use those, by the way, in the treatment of diarrhea in infants very frequently, by the way, so it's not strange. We started using them in patients with uremia, or you can give both. You can give complex carbohydrates and the bacteria, which is what we call symbiotics. Give them to the patient to eat, and it has affected actually the levels of the toxins, but these studies are just at the beginning. We don't know if it's going to be useful clinically at the end of the day or not. So now we come to the summary. So uremic toxin glossaries, as we said, are being constantly updated. Every now and then we hear about a new toxin, we learn more about that toxin. Protein-bound uremic toxins are a problem because we cannot remove them by the conventional dialysis techniques and not even by the high flux techniques. Indoxyl sulfate and p-cresol sulfate are among the most well-studied protein-bound uremic toxins, and they are very toxic, definitely. Reducing their levels is possible, is achievable by dietary restrictions, intestinal adsorbents, some forms of extracorporeal removal, antidotes, manipulation of the bacteria. So we can reduce their levels, but we still don't have any data if this is going to be useful or not. But we should keep an eye, because there's a lot of research going on in this field, and very soon I think we will have certain tools to use in order to manipulate and reduce the levels of those toxins in a beneficial way. Now I know it's time for lunch. I know you're very hungry, so I'm going to present you with this very beautiful plate. Actually, maybe one day this is going to be the easiest way for prevention of progression of chronic kidney disease and inflammation in our patients, because this dish, you'll find people selling it outside the university hospital in the streets, and it's what we call food, it's bean. And this has lots of fibers. Legumes have lots of fibers, they have lots of insoluble and soluble fibers that can be decomposed by the saccharolytic bacteria in the intestine and act as prebiotics. And of course, if you buy it from the man in front of the hospital, I'm sure it will be filled with saccharolytic bacteria, it will be filled with all types of bacteria. So it's also going to be very useful. And perhaps this is one day, maybe we can do a collaborative research and see how food can help our patients. But to end with, I'll give you those two quotations. One of them is from 1888 and one of them is from 2012, and you'll be very clever if you tell me which one is the old one and which one is the new one. Thank you very much.
Thank you very much, Professor Nsr, for this presentation. Now it's open for questions. Yes, please.